thank Archana ji. I will like to thank Archana ji for your kind invitation and give me this platform to interact with all the dietitians. As we know that the diet is a very important component of any treatment disease, and we cannot go without it. So I thought that I will give some nutritional advice on the liver disease part, because every disease has a different nutritional component to it. So gradually, maybe in a few more things, I can ask about nutrition in acute pancreatitis or nutrition in IBD. Uh, so next slide, please. So greetings from Yashoda Medicity, which is going to be shortly launched in the next year in March. So I welcome you all to visit the hospital sometime. Next slide, please. Next slide. So the outline of my lecture would be in terms of methods, background, guidelines, and the future. Next slide. So as we know that the burden of cirrhosis is very high, malnutrition, definition, and mechanism and potential targets for sarcopenia. Next slide, please. So prevalence and implication of malnutrition, sarcopenia, and cirrhosis. Malnutrition is a frequent burden in liver cirrhosis. As we all know, it is almost reported 20% of the cases of compensated cirrhosis, and more than 50% of the patients of decompensated liver disease suffer from malnutrition. The progression of malnutrition is associated with progression of liver failure. While malnutrition may be less evident in compensated cirrhosis, it is easily recognizable in decompensated patients. Both adipose tissue as well as the muscle tissue can be depleted. Female patients are in fact more frequently and likely to develop a depletion fat deposits, while males are more rapidly lose the muscle tissue. Next slide. So malnutrition, muscle mass, which is also known as sarcopenia, has been used as an equivalent of severe malnutrition, are associated with higher risk of complications. The risk of which are susceptibility to various infections, hepatic encephalopathy, ascites. It is an independent predictor of lower survival among cirrhotics and in patients undergoing liver transplant. Malnutrition and sarcopenia should be recognized as a complication of cirrhosis, which in turn further worsens the prognosis of cirrhotic patients. So that is the very importance of nutrition. The term malnutrition refers to both the deficiencies and to the excesses of nutritional status. In addition to undernutrition, cirrhotic patients are overweight also, and obese are increasingly observed due to increased number of cirrhosis related to NASH. Muscle mass depletion also occurs in these patients, but due to coexistence of obesity, sarcopenia may be overlooked. Obesity and sarcopenic obesity may further worsen the prognosis of such patients with liver cirrhosis. It is important to know that only BMI or weight is not a marker for nutrition or malnutrition. You can see the muscle mass also, the triceps circumference, bicep circumference, and also these days we are also promoting for muscle strength dynamometer. It can be kept in the hospital OPD, and patient can be asked to know what is the strength of the muscle using the palm. Next slide, please. So these are the various terminologies which have been used. Deterioration of muscle function capacity related to immobility and chronic disability. Frailty is loss of functional, cognitive, physiological reserve leading to a vulnerable state. Frailty may be considered in the form of nutrition-related disorder. Immunonutrition. In this terminology, basically it means that specific nutrients in an attempt to modulate the immune system, not necessarily in the presence of nutrition and functional to improve the health rate. Examples include enteral nutrition formulas enriched with omega-3 fatty acids, arginine, glutamine, and nucleotides. Malnutrition, it refers to a nutritional disorder which results from a lack of intake or uptake of nutrition that leads to altered body composition and body cell mass leading to diminished physical and mental function, impaired clinical outcome. In the present CPG, we have used malnutrition as a synonym for undernutrition. In muscle wasting, the active progressive loss of muscle mass due to underlying disease, ultimately leading to muscle atrophy. Most inflammatory diseases induce muscle wasting. Sarcopenia refers to a reduction of muscle mass and function due to aging, or it may be acute due to acute or chronic illnesses, including CLD. Undernutrition is synonym for malnutrition, as has been described above. Next slide, please. So this is the mechanism and of sarcopenia. Anabolic resistance and dysregulated proteostasis results from failure to respond to standard supplementation. These are the mechanisms which are the potential therapeutic targets also. So not only hormone replacement, antibiotics, gun microbiome, this all lead to increase ammonia and also a negative nitrogen balance may be done, which leads to muscle contractile function decrease and proteolysis and reduction of muscle mass. Next slide, please. So what are our guidelines? The key recommendations include, next slide, please. First, the screening and assessment of malnutrition, obesity, and liver cirrhosis, nutritional management and principles in patients with liver cirrhosis, micronutrients, nutritional treatment options for hepatic encephalopathy specifically, nutritional treatment options for cirrhotic patients done with in bone diseases, malnutrition in patients undergoing liver surgery and liver transplantation, malnutrition in critically ill cirrhotic patients, and future of nutrition in chronic liver disease. These are the various topics in which we will discuss the various aspects. Next slide, please. Now, how do we screen in malnutrition, obesity, in liver cirrhosis? Who, when, and how to screen for malnutrition? So we should perform a rapid nutrition screen for all patients of cirrhosis and complete detailed assessment of those at risk of malnutrition to confirm the presence of and severity of malnutrition. We should assume for malnutrition to be high if the BMI is less than 18.5 or a child Cook score of C. In all other cases, utilization of nutritional screening tools to assess the risk of malnutrition. The diagnosis of obesity is done if the BMI is more than 30, and you have to take up the confounding effect of the fluid retention, estimate dry body weight, and although the accuracy may be low, but if the patient is child C or has massive ascites, you have to discount for the same. Next slide, please. So this is a very busy slide in which we can see the nutritional assessment and screen of the patient of cirrhosis has to be done. Then we have to find out whether the child patient is child A or C. If it is C, it becomes a high risk. If it is A or B, then we have to see for the BMI. If the BMI is less than 18.5, it is underweight, and if the BMI is more than 30, it is overweight and obesity is there. So you have to screen for various malnutrition and nutritional assessment has to be done, and you have to stratify the risk of the patient, whether the patient is high risk, medium risk, or low risk. And we have to give the assessment and we have to give the diet according to the same. Next slide. So nutrition, what are the nutritional management principles in a patient with liver cirrhosis? Start nutrition counseling by a multidisciplinary team, support the patient with adequate calories and protein intake in patients with malnutrition and cirrhosis. Calories is very, very important, especially in a case of alcoholic liver disease. The optimal energy intake should not be lower than the recommended 35 kilocalorie per kg body weight. So for a 60 kg patient, it should be around 2000 kilocalories should be done. And it is important to have a protein intake of 1.2 to 1.5 gram per kg body weight. That means a 60 gram patient should have a protein intake of 70 to 90 grams. We should not be fearing that a patient will go into some kidney disease or will not be able to process, because whatever protein loss that you are not giving through the diet, body will actually cut off the muscle mass and try to take that protein for its utilization. So in fact, that will increase the sarcopenia. So if you are not giving adequate proteins, patient will land up in decreased muscle mass and sarcopenia. It is very important that include late evening and nutritional supplementation and breakfast containing some proteins in malnourished and decompensated cirrhotic patients. A very important is that we should use BCCA, branch chain amino acid supplements, and leucine enriched amino acid supplements should be considered for decompensated cirrhotic patients. In patients with malnutrition and cirrhosis who are unable to achieve adequate daily dietary intake with oral intake, even with oral supplements, a period of enteral nutrition should be recommended. Next slide, please. So again, furthering the nutrition management principle in patient of liver cirrhosis, Avoid hypomobility in cirrhotic patients and propose a personal physical activity program even in decompetent liver disease patients. Implement a nutritional lifestyle program for a progressive weight loss in obese cirrhotic patients, those who are more than 30 kilogram per kg body weight corrected for water retention. Adopt a tailored, moderately hypocaloric, including adequate amount of proteins to achieve weight loss without compromising the protein stores. So what this says that even if you are those patients who are obese and who are you want to reduce weight, please do not cut on the protein intake, which should be maintained at 1 gram. You can decrease the calories for weight loss, but do not decrease the protein. I would suggest the RDC of the protein is usually very high. That means that while you digest the protein, a lot of energy is required for digestion. That also goes in favor of reducing the weight. Next slide, please. The micronutrients are very important. Cirrhotic patients, you should administer 9 micronutrients, vitamins to treat and confirm clinically suspected deficiency. Assess vitamin D levels in cirrhotic patients as deficiency is very highly prevalent. This is true for all patients in India, but it is more so in CLD patients. Supplement vitamin D orally in cirrhotic patients with vitamin D levels less than 20 to reach a serum vitamin D level of more than 30. In cirrhotic patients, this is very important. In cirrhotic patients with ascites, the sodium restriction should be around 2 gram. In all other non-decompensated patients, you can give up to 5 gram of salt. This is very important. Extra salt is to be absolutely avoided, and you have to tell them that please maintain your salt intake between 2 to 5 gram. If it is decompensated, then you make it 2 gram. If it is compensated, you have to make it 5 grams. Although there may be issues of some palatability issues with the regimen, but you have to try to reduce the salt intake. Next slide, please. Nutrition options in patients with hepatic encephalopathy. It is very important to understand the nutritional issues. Always evaluate the nutrition status in sarcopenic patients, in the sarcopenia, in the patients of hepatic encephalopathy. Avoid protein restriction in diet with HE. This is very important. Normally, our first thing is that we reduce proteins. He has encephalopathy, he has liver disease, we reduce the proteins. That should be avoided. You have to give optimal daily protein with energy intake should not be lower than the general recommendations for cirrhotic patients. At the same time, we have to encourage the consumption of vegetables and dairy proteins. BCAA supplementation can be done in patients with who can tolerate the oral intake. Prefer dietary intake by mouth in patients with 3 and 4 encephalopathy who are unable to eat. Provide nutrition using NG tube in protected airways patients or parentally. Next slide, please. Now dietary advice for bedside or OPDation. Most of your thing is rare and restriction between food and limited and scientific. Generally, healthy eating of variety of foods is advisable. No food other than alcohol should be avoided, and no food can damage the liver. Generally, containing in patients with chronic liver disease. Most of the patients with chronic liver disease eating adequate amount of calories and protein is much more important than avoiding specific type of food. This is very important in OPD also because in India, any patient who comes to us always asks what diet we should give. In alcoholic patients or CLD patients, we should be saying that you eat everything. Even paranthas, puris, all can be in because most important thing is to have adequate calories. 2000 calories should be there and 1.5 gram, 1.2 to 1.5 gram of protein should be there. This is the most important thing which is there. So it is not that you avoid anything, but a good balanced diet and variety diet which you can enjoy should be given. Next slide, please. You should now coming to this is a very important point we should take note. You should split your food intake into 3 main meals: breakfast, lunch, and dinner, and 3 snacks also, which is mid meals, mid morning, mid afternoon, and late evening. Late evening snack is the most important as it covers a long interval between the dinner and breakfast. This is very important because we know that the glycogen storage, glycogen is stored in the liver, and in liver disease because the glycogen storage decreases So likelihood of reduced sugars and other things occurs in the early morning cases. So it's very important to have a late night snack. You should try eat as many fruits and vegetables as you can without making you bloated. You should try not to add too much of salt. That is to be avoided fully. However, if you keep feeling that this makes your food unpleasant to eat, you can always try alternatives. Next slide, please. Patients with liver disease may have hepatic encephalopathy, may make them tolerate animal proteins less. So in those, I only ask patients to avoid red meat, but other than that, they can have white meat very commonly. Before you make any changes in your protein, you should always ask your doctor or dietitian. Please do not reduce the total protein intake as it is not advisable. In cirrhosis, some patients with liver disease have other diseases, for example, diabetes or overweight, obese, which may have further dietary adjustments. Next slide, please. So this is dietary management in bone disease in patients, which is very common in chronic liver disease. We have to do DEXA scans. Next slide, please. So risk factors for development of osteoporosis is chronic liver disease, alcohol abuse, smoking, body mass index, early menopause, secondary amenorrhea, family history of osteoporotic fracture, treatment with corticosteroids, especially in alcoholic liver disease, advanced age. Next slide, please. So nutritional requirement options for patients with bone diseases, you must include BMD for cirrhotic patients, utilize the lumbar and femoral densitometry for diagnosing osteoporosis, lateral access of, can also be done. Repeat the DEXA after 2-3 years. We must include supplements of calcium, 1000 to 1500 milligrams per day, and also vitamin D, 400 to 800 IU per day or every 2 weeks. And in patients with CLD, T-score of less than 1.5. You can utilize bisphonates in cirrhotic patients with osteoporosis in those waiting for liver transplant. Consider testosterone supplementation, venesection, males such as hemochromatosis or hypochondrosis. Next slide, please. So malnutrition patient undergoing liver surgery, liver transplantation, not many patients, but we are at Yashoda starting off with liver transplantation shortly. So we must include screening for malnutrition, liver cirrhotic patients, screen for sarcopenic obesity, body composition. Preoperatively, the treatment goal is maintenance of nutritional status, energy intake of 30 kilocalories and 1.2 gram per kg body weight of proteins. Preoperative nutrition utilizes a standard nutrition regimen, especially BCAA, branch and amino acid enriched immune enhancing diets. Next slide, please. So again, after liver transplantation, initiate normal food. When oral and enteral nutrition not possible, impactable, you have to, after acute post-operative phase, give an energy of 35 kilocalories and a protein intake of 1.5. Consider PN, parenteral nutrition, patient with unprotected airways and hepatic encephalopathy, and utilize enteral tube feeding or PN for reduced target energy intake. Next slide, please. So this is also very important, especially in malnutrition in critically ill cirrhotic patients in the ICU. Consider nutrition status and presence of sarcopenia. Supplementary dietary intake by enteral nutrition in critically ill cirrhotic patients who are unable to achieve adequate diet by mouth. If oral diet or enteral nutrition is not tolerated or contraindicated, consider parenteral nutrition. This is very important, especially in alcoholic liver disease, also in sometimes alcoholic hepatitis who are in the ICU. We give a short course of or 1 liter of parenteral nutrition in addition to what the patient is in. Because in many of the times of alcoholic liver disease, they need 3000 kilocalories of patients. Also, many times we ask our dietitians to actually map because what we on the rounds we may say 2000 kilocalories or 3000 kilocalories. Sometimes we have to assess whether the patient is able to take or not. That is very important.
Very important.
That is very important that we have to sometimes assess, audit, dietary audit. I recommend sometimes when I'm seeing that the patient is not able, because then we have to plan that we have to supplement it by palantrol. We have to give sometimes motivate the patients for liver disease patients. Nasogastric tubes are not contained in patients with non-bleeding urethritis. We should also avoid PEG insertion in cirrhotic patients due to risk of bleeding. Next slide, please. So again, take care of the daily energy requirement of 35 to 40 kilocalories and 1.2 to 1.5 gram per kg body weight of proteins. Standard nutrition regimens, no advantage has been shown for specialized regimens. In patients with hepatic encephalopathy, consider branch and amino acid enriched solutions. In cirrhotic patients, severe or alcoholic hepatitis, consider nutrition support as it may accelerate the resolution of hepatic encephalopathy and improve survival in patients with low calorie intake. So this is very, very important that your nutrition can improve survival in patients. So what is the future? Future of nutrition chronic liver disease? There are few things which you may say. Newer research should answer, does improvement of muscle mass or muscle function improve clinical outcomes? Do ammonia-lowering strategies can compensate cirrhosis? Uh, does gradual increase in physical activity delay or reverse the muscle loss of contractile dysfunction and exercise duration, which may be beneficial? Next slide, please. In addition to supplements needed to lower ammonia and increase mitochondrial intermediates, to these are the various research questions that we might say at your end. If you anybody wants to do some research in diet and liver disease, so may take up these topics for this thing, which need solution. And how to overcome the anabolic resistance and reverse the underlying causes of anabolic resistance. Next slide, please. In absence of indirect calorimetry, what is the best way to calculate the energy needs of critically ill patients? Does the energy and protein intake improve outcome? And should nutritional recommendations differ according to nutrition status at the baseline? Next slide, please. Thank you very much for your kind attention. And I once again thank Archana Madam for giving me this opportunity to interact with you all.
So, sir, it's my privilege to have you here, and really thankful to you to give us all of us insight about the liver diseases. Anyone have any questions? Like sir very rightly said, whenever we are going for the rounds, sometimes patient is not able to have that type of total calorie intake and the total protein. Especially not only the patients are normal human being also not able to take the proper 1.2 or 1.5 gram of protein per day. Many times we have just assessed the normal patients, they are just taking around 30 or 40 gram if they are vegetarian specifically. Non-vegetarian, yes, a little bit can be added over there. But for the vegetarian, it's very difficult to manage this type of protein.
Yeah, so that is very important because I say all my patients that you take one protein dish in every meal,
True.
morning, evening, and night, and then supplement by protein supplements and other things. Because
Very
otherwise,
true.
they are not able to take the adequate protein. And those patients who are having muscle loss, they become weak, they cannot walk, physical debility is there, and survival is definitely decreased in
Very,
them.
very true, sir. Very true. Anyone is having any questions related to the digestive diseases or liver cirrhosis or liver diseases? Please feel free to ask, or you can just message us. I can convey to the sir. Any addition? Tanvi, Gitanjali, Nino, Sonali, you are facing some of the issues with the gastric release. You can ask any question of yours.
सर हेलो सर गुड इवनिंग।
Yes, ma'am.
हाँ मेरे को मतलब मेरा क्वेश्चन ये था जैसे गट की प्रॉब्लम आजकल डे बाय डे बढ़ती जा रही है बट
जी।
ऐसे में मतलब हमारा एजिंग फैक्टर भी इफेक्ट करता है तो एज अ ओल्ड एज या फिर कह सकते हैं कि डिफरेंट एजेस पे हम अपनी गट को कैसे मेंटेन कर सकते हैं अपनी।
देखिए सबसे इम्पोर्टेंट जो चीज है गट को मेंटेन करने के लिए वो है बैलेंस डाइट, गुड फूड, गुड डाइट। बैलेंस डाइट मतलब आप डाइटिशियन हो, आपको बताने की जरूरत नहीं है। कार्बोहाइड्रेट्स भी होना चाहिए, प्रोटीन्स भी होना चाहिए, विटामिन मिनरल्स होना चाहिए। तो ये सारा बैलेंस डाइट हमें बोलता है एडुकेट कैलोरीज ऑल्सो, एडुकेट प्रोटीन्स ऑल्सो। सेकेंड थिंग, यू शुड ऑल्सो बी फिजिकली एक्टिव। You should at least half an hour to 1 hour of walking every day, that you should be there. And also try to reduce some stress by doing meditation and other things so that you have a wholesome life. And don't, आजकल होता क्या है, because of the tendency we tend to घर पे कोई nobody wants to cook, everybody wants a Swiggy or Zomato, or may take shortcuts or may go burgers or pizza. So that is very important and that is very difficult. Also, the in old age people, what is there, that physical activity is very decreased. So what happens is, if physical activity is, they do not take adequate of foods, and if they do not adequate food, then they lose on the weight and other things, and also the energy levels are also going down. So that is very important to have good physical activity, even if it is by using a walker or take anybody with them and using a stick also. but they should do a good amount of 30 minutes of walking every day, even if it's slow. So that will help them. Also, that helps in constipation also, because if they are mobile, so their bowels are getting free, and if they are taking good vegetables and good amount of fluids, their bowels are very free. So that also will help them to maintain a good gut life.
Very true, sir. Like mobility is also very much important, along with the proper diet and the management of any diseases. Yes, sir? Yeah.
Hello,
Yes, ma'am.
good
Yeah.
afternoon, sir and ma'am.
Yeah, Tanvi.
हाँ जी सर, आई जस्ट वांट टू नो दैट ब्लोटिंग इश्यूज आजकल काफी रहते हैं लाइक क्लाइंट्स को, तो ब्लोटिंग के हम क्या सजेस्ट कर सकते हैं, लाइक अगर वो रेगुलर भी मील्स ले रहे हैं, आफ्टर 2 hourly दे आर कंज्यूमिंग एनी मील्स, और आजकल वाटर्स भी बहुत सारे, वाटर हो गया या अजवाइन वाटर, जो भी मतलब डाइटिशियन सजेस्ट करते हैं, तो फिर भी उनको ब्लोटिंग रहता है, तो ब्लोटिंग के लिए पर्टिकुलरली हम क्या बता सकते हैं उनको, ताकि उनका गेट नेचुरली थोड़ा सा हेल्दी रहे।
Yes, ma'am. Ma'am, for floating, we actually have to prescribe low FODMAP diets. तो fermentable होते हैं ना, less FODMAP diets. मोटा मोटा ये है कि you have to ask them to avoid rajma, chole, फूल गोभी, and you can go to the net and find out that there is a set of low FODMAP diets. You have to avoid FODMAP from your diet. That will decrease the bloating. At the same time, you have to decrease some amount of acidity, like citric fruits and juices, so that will decrease the bloating part. And also, if they are mobile, then this bloating will decrease. And they should pass stools every day, then there will be no gas. And they should decrease the methane containing foods from eating.
Right, sir.
थैंक यू सो मच सर।
Anyone
सर
else? Yeah.
मैं डॉक्टर दीपक शर्मा, एक होम्योपैथिक फिजिशियन हूँ। डॉक्टर
जी
अर्चना के साथ काफ़ी टाइम से जुड़ा हूँ। सर
जी।
एक प्रॉब्लम डिस्कशन करनी है कि जितने भी हमारे पास अभी जीआईटी के पेशेंट हैं, उसमें से हम लोग जो पानी पे काम कर रहे हैं, मतलब पानी पीने का जो वो है सेंस, जैसे कि मैं कहता हूँ कि जो आरओ का पानी पी रहे हैं उसको भी बॉयल करके पी लो। तो पानी एक ऐसा इशू हो गया है, मुझे लगता है कि बहुत कॉमन है। तो इसके बारे में आपका कोई वो कि किस तरीके का पानी पीना चाहिए?
देखिए, आरओ में प्रॉब्लम कोई नहीं है, आप आरओ का यूज कर सकते हैं। प्रॉब्लम सिर्फ में आरओ में है कि यू हैव टू नो द टीडीएस, कि टीडीएस कितना है। बहुत ज्यादा अगर 50 से भी कम टीडीएस होता है तो वो भी डेंजरस होता है। एंड 50 to 150 टीडीएस आपको आरओ का रखना पड़ेगा। सेकेंड इज नॉट ओनली, जब वो वाटर लेते हैं तो उसके यूटेंसिल्स भी आपको यूज करना पड़ेगा, कौन सा यूटेंसिल आप यूज कर रहे हो। इफ द यूटेंसिल इज बैड, देन योर लाइक्लीहुड ऑफ गेटिंग जीआई इन्फेक्शन इज वेरी हाई। सो एक तो आरओ का रायन एक शुड बी, टीडीएस शुड बी बिटवीन 50 and 150, and the utensils that you use should also be good. You can, somebody can, who is more finicky, can boil the water, but otherwise it doesn't give you any prior advantage by boiling water. कुछ लोग ठंडा में गुनगुना पानी यूज करना चाहते हैं, but that is for the tongue, because ultimately whatever you drink, it goes into your stomach, which is kind of at 37 degrees. So whether you take ice cold water or you take warm water, ultimately when it goes into your stomach, it reaches 37 degrees only.
Okay,
सर
sir.
वो बॉइल्ड वाटर से मेरा मतलब नहीं था कि गर्म पानी पिए। मेरा मतलब था कि हम उनको बोलते हैं कि जैसे पहले पुराना तरीका था कि आप पानी को बॉईल करके रख लो और पूरे दिन उसी को कंज्यूम करो। उससे मेरे बहुत सारे पेशेंट को जो गैस बन रही थी, जिसको हम ठीक भी नहीं कर पा रहे थे, वो सिर्फ मैंने पानी के उससे ठीक किया है। तो मुझे लगता है कि जो पानी हमें हमारे यहाँ सप्लाई हो रहा है, वो उस पर भी हमें ध्यान देना चाहिए। बहुत सारे लोग जैसे कहते हैं कि बाहर जाते हैं तो ठीक हो जाते हैं, दिल्ली में आते हैं तो पानी पीने के बाद ही बहुत सारे
Yes.
गैस की प्रॉब्लम आ जाती हैं।
तो क्वालिटी ऑफ वाटर इज डेफिनेटली इम्पोर्टेंट, एंड समटाइम टीडीएस भी होता है बाहर का। दिल्ली का हो सकता है कि किसी एरियाज का पानी ज्यादा हार्ड होता है, इसके वजह से भी हो सकता है। आप कर सकते हैं, इफ दैट गिव्स यू सम बेनिफिट, व्हाई नॉट।
ठीक ठीक, थैंक
बट
यू सर।
साइंटिफिकली इट मे नॉट बी प्लॉजिबल, दैट्स
Yes.
व्हाट आई एम।
ओके, थैंक यू सर।
सर एक क्वेश्चन आया है कि
जी।
खाना खाने के बाद भी पेट में लाइक हल्कापन लगता है, भूख, ऐसा लगता है कि अभी भी पेट भरा नहीं है, भरा मतलब खाली खाली फील होता है पूरा खाना
अच्छा।
खाने के बाद भी। तो ऐसा
ओके।
क्यों लगता है और उसे कैसे मैनेज किया जाए?
हाँ, तो ये थोड़ा ब्लोटिंग का पार्ट है। तो अगर आप या तो हो सकता है कि आप जितना आपको भूख है उससे कम ले रहे हैं, तो यू कैन ऐड ऑन टू सम फ्रूट्स एंड वेजिटेबल्स टू योर
Yeah.
diet, so that will help you, that will increase the amount of quantity of the food that you eat, so that will help. Or the second thing is, if you don't want to take too much of calories, you can take a glass of water extra. That also will fill up your stomach and you have that feeling.
Right. Right. ज्यादा लेने, सर उनका फिर से क्वेश्चन एक आया है कि अगर हम ज्यादा ऐसा करते हैं तो उसके बाद फिर गैस बहुत बनने लगती है,
क्या करते हैं तो?
एसिडिटी। अगर
एसिड?
ज्यादा थोड़ा सा ले लेते हैं तो एसिडिटी बनने लग जाती है।
ज्यादा क्या ले लेते हैं?
ज्यादा फूड ले लेते हैं या ज्यादा फिर पानी अगर ले लेते हैं तो, या खाना खा
तो
लेते हैं।
वो आपको देखना पड़ेगा, कभी कभी फ्रूट्स में ज्यादा मीथेन होता है, ज्यादा फॉडमैप होते हैं, तो आपको क्वालिटी ऑफ फूड और टाइप ऑफ फूड, तो यू हैव टू टेक लो फॉडमैप फ्रूट्स एंड
जी।
वेजिटेबल्स, जिससे आपको ब्लोटिंग नहीं होगी.
जी।
द क्वालिटी ऑफ फूड हैज टू बी डिफरेंट.
राइट। एनी अदर क्वेश्चंस?
There,
मेरा सर
या
there is a controversial about the regarding to that only. The patient is suffering from the liver cirrhosis. In that particular patient, we observed that during the ascites, yeah, ascites, we will sodium restricted diet will be planned. And second thing that the BCAA and control of the amino acid, this aromatic amino acid, that is a much important for that. So what ratio will be choose for that? If suppose we will give the in kind of the this one only for the biological value protein, in such cases sometimes the ammonia will be increases. So this is a very much important part. The dietitian should be maintain or mention each and everything whatever she or he will advise. We have to be proceed according to balance of the BCA branch and amino acid and aromatic amino acid.
यस, राइट सर। Thank you so much, sir, Dr. Abdul. One more question is there, sir, from Sonali. After gallbladder removal, does the belly fat increase? Which organ takes place of the gallbladder?
No, no. So the belly fat doesn't increase. And second is basically the CBD, the common bile duct which is there, which is bringing the bile from the liver to the duodenum, that increases by diameter by 1 or 2 mm, and that can only use as a storage organ. So there is no problem in digestion, and when the body requires, the adequate bile will flow. So there is no problem.
Right, right. Okay. She's saying like after 2 years of gallbladder removal, I have issues is like gastric issues came arises. Earlier they were not there. So it.
Sometimes it's there that they may have some bile acid related issues. So you
Mm.
can try out the PPAs and other things, and sometimes you can take a short course of ursodeoxycholic acid and see if it helps. In very rarely, in some cases, bile acid related issues do crop up post gallbladder, but it is very few. And most of the time, what happens is you may have some dyspeptic symptoms. So that will may go with taking a short course of PPAs and other things. So, and also you can do good diet management, like you avoid citric fruits and juices, you add rajma chole, you add too much of fatty food. So those food related restrictions, if you do, maybe that will also go away.
Right, sir. And she also is like saying like if gallbladder has been removed, then whether any other organ take care of that part of that function of the gallbladder.
That's what I said. No,
Yeah.
CBD size increases by 1 or 2 mm.
Right.
Like normal CBD is 5 to 6 mm. In post cholecystomy, it is actually in 8 to 9 mm. It takes over, so that it can take over the function of the gallbladder.
Right, right. I think Sonali, now it's clear to you. Yeah. Any other questions? Tanvi, dietary part and the management part we will take again, Abhi. After the session, I will take that session. We'll clear out all the queries of your diet. Yeah.
मैम आई हैव वन क्वेश्चन।
Right.
जैसे सर अर्ली एज बच्चों के लिए हम क्या गट हेल्थ हैबिट्स रख सकते हैं अर्ली एज पे कि बच्चों को गट की प्रॉब्लम्स ना हो, तो उनके लिए हम कैसे गट हेल्थ जो हैबिट्स हो या कुछ चेंजेस हो अपार्ट फ्रॉम लाइक डाइट तो
So
ठीक है, उसके
early
अलावा
age,
भी
which age group you mean? Early age, which age group you mean?
मतलब सर अर्ली एज लाइक आपकी जो स्कूल एज होती है, टीनेज एज होती है, ये सारी एजेस मतलब जिसमें अपार्ट फ्रॉम डाइट तो ठीक है, पर उसके अलावा भी कौन कौन सी हैबिट्स हम रख सकते हैं कि जो बच्चों को गट हेल्थ या कोई भी इश्यू ना हो।
ठीक है, this is the most difficult age period to maintain because they are always complaining and they are always grandfathers and grandmothers to do alternate things. But see, ultimately, what is good is if you can provide them with balanced diet. Balanced diet is you do not give them refined sugars, you do not them refined carbohydrates, you give them multigrain carbohydrates, you give them complex sugars, you give proteins, and you give them vegetables and fiber. That is very, very important. The problem with the younger age group is that they do not do all these things, and neither their parents have the time to and energy to try to force them to do all these things. So they go into refined sugars and refined simple carbohydrates. So they take colas, they do burgers, they do pizza. This all increases the calories and they are less in nutrition. So what happens is childhood obesity is a very, very big problem, and I have seen patients of 7, 8 years having 70, 80 kg also. So that is a big, big problem to give them nutrition. So that, as I had mentioned in my lecture also, that undernutrition is an important thing. Overnutrition is also actually malnutrition. So that should be appreciated, and we should try and give the balanced diet to the even this children, all children of all age groups, so that they can take adequate calories, proteins, fruits and vegetables, and also maintain a healthy lifestyle. So that is very, very important.
Right.
थैंक यू सर।
Anyone question?